Okay, welcome back to today's webinar on knee osteoarthritis. And today's webinar is focused a little bit more on the BioFlex Personal Therapy System. And this is a home system traditionally purchased by patients who have either received BioFlex laser therapy in a clinical setting and want to start treating at home in conjunction with clinic or on their own, or have just want an alternative to the things that they're using to treat. So the webinar is not so much geared towards BioFlex healthcare professionals specifically to treat knee osteoarthritis, although the content of the information I think will still be very helpful. Just keep that in mind. I also do webinars specifically for healthcare professionals and BioFlex laser therapy as well. So I did do one recently on arthritis, so just so you know. And usually I do these webinars twice a week. They're recorded, or sorry, twice a month, and they're recorded, and we try and send out the link to everyone that has registered. So if you can't get a chance to listen in live, then you can certainly watch it whenever you'd like to, or rewatch it, or what have you. As I mentioned, I am the Director of Education and Training, or maybe I did mention that, and I'm a chiropractor. I've been using laser therapy for well over a decade, been practicing for about 3 decades. And I find that these webinars are quite useful to provide information, not only on laser therapy, but other up-to-date evidence-based guidelines for treatment of certain conditions, typically within the scope of practice of physios and chiropractors, massage therapists, naturopaths, and so forth. So what I'm going to cover today is just a brief overview, as I usually do, of our BioFlex Personal Therapy Systems, and then a little bit about osteoarthritis. There's a lot of misinformation, you might say, out there. So I want to clear that up. This is all based on recent research. And then I'll talk a little bit about what's out there as far as other treatments other than laser therapy, so you can have an understanding of that as well. And then specifically why you would be using photobiomodulation therapy or low-level light therapy or laser therapy. There's different terms for it. And then I'll get into actually using the equipment and talk a bit about how you might approach treating your knee osteoarthritis. And I'll always have time at the end for Q&A. So we make 2 different types of home systems. They're very similar. Really, what's different about them is that the actual light array is a little bit larger. It has 180 diodes in the BioFlex P180, as opposed to 120 diodes in the P120. So really, it's just a matter of surface area that it's treating. So if you're a larger person or you're treating larger areas of your body, then the P180 might be a little bit more efficient. If you're smaller in stature, or perhaps treating not as large areas, in the P120 is good. Of course, you can use a P120 wherever. You just might have to do extra placement or 2. That's all depending on your size, but the actual output and power and so forth is the same. I might say as well, so as far as the output of energy, it's pretty much identical to what we would use in a clinical setting. The real differences are that this is a flexible silicone array. The LEDs, or their superluminous diodes, are embedded into the silicone. It's not designed to be used in a clinical setting in the sense of repeated use, 6, 7, 8, 9, 10 times a day for every day for weeks and months and years. So the professional systems are more robust, obviously, to use in a clinical setting, but the actual efficacy is the same. Now, the diodes are interesting because they're bicolor, and so each diode emits 2 wavelengths. Now, it doesn't do that at the same time. The first wavelengths that come out is red, and the second one that comes out is in the near infrared spectrum. But because they're out of one diode, and the way that they're kind of packed in close together gives you a very intense amount of energy or light into the tissues, and that's really critical when you're trying to use something like photobiomodulation. By the way, if you have any questions, type them into the Q&A at any time. I'll try and get to them. Well, I probably will get to them at the end of the lecture as opposed to during, just because it breaks up the flow as I'm speaking. But I invite you to ask me questions along the way, and I'll get to them eventually for sure. So the system's controlled by a little controller. It has specific protocols starting from the face and neck all the way down to the foot and the ankle. So obviously today we're going to be using the knee protocol. And if you look at the lower portion of the controller, you can see there's a timer, there's a power button, a stop treatment that completely stops your treatment, a pause and or start button, and a stage, which I will get into at the end of today's lecture. So let's talk a little bit about osteoarthritis. Obviously, it's a really common condition. It affects almost 40% of people over 60 years of age. And this was a health survey done not that long ago, and that was based only on radiographic examination. So the number is actually probably much higher. And it tends to be higher in women than men. There's multiple reasons for that probably. But a big one is the angle, the Q angle of the femur on the tibia. There's a bit more stress on the inside of the knee, and this can lead to earlier signs of wear and tear, you might say. So obviously the prevalence of osteoarthritis, given our population is aging, of course, is going to increase. So that's a no-brainer, right? We all know that people are living longer and they're trying to do more and more. And, you know, you have to understand that this is a progressive disorder and that eventually everyone's going to get some wear and tear arthritis, but you want to be proactive and slow it down so that you can be as active, especially in the knees, as possible. So really, osteoarthritis represents failed repair of joint damage. This is ongoing joint damage from different stresses on any specific joint or the periarticular tissue, which is just the tissue that surrounds the joint. And I'll talk about that shortly. So when I talk about tissues that surround the joint, you know, when you treat osteoarthritis, you should not just be treating sort of the joint. There's other tissues involved, like muscles, right? So if you've ever felt or palpated your muscles around your arthritic knee, they might be tender or sore. So they should sometimes be treated as well. There is bone issues. There can be what's referred to as bone remodeling and sclerosis as well. Of course, there's hyaline cartilage degradation. There can be ligamentous degradation as well. And on the inside lining of the joint capsule is a synovial membrane that, of course, can also be problematic and release inflammatory chemicals that causes the ongoing progression of arthritis. And there are osteophytes, which are bone growth due to mechanical stresses. And in the knees specifically, there's meniscal cartilage. Everyone's aware of that. But this is the one that when it starts to degrade or tear, very common in sporting injuries, but also very common as we age, it starts to degrade and starts to get little micro tears. And it used to be that surgeons would just love going in there and shaving and cleaning and doing all this stuff. And wouldn't you know it, that was an evidence-based treatment. That was just, hey, I'm a surgeon, I'll do that. And now we know that actually that's not what you want to do. So for decades and decades, that approach was actually not helping. So although the cartilage loss is fundamental of osteoarthritis, this disease really is a function of the entire joint. Excuse me. So the symptoms and signs of knee osteoarthritis, I'm sure everyone's aware, from pain and stiffness, or you'll get sometimes reduced motion or ability to move your knee in a certain manner. And you might also start to feel weakness. And that's really, really important as you age because muscles tend to lose their strength. And last thing you want is your knee to give out when you're walking or climbing downstairs, because that can lead to even greater injuries. So long-term consequences of osteoarthritis, this can include reduction of one's physical activity, deconditioning. It can affect one's sleep and fatigue, and obviously chronic pain can lead to depression, ongoing disability. So it's a really problematic issue. And of course, that's probably why you're watching today's webinar. The symptom severity and structural damage on imaging is often discordant. In other words, someone can have a lot of pain and symptoms and not necessarily see that on the x-ray. So I'm not a huge fan of x-raying the knees unless it makes sense, because really a diagnosis of osteoarthritis, although it's definitive with an x-ray, it can almost always be sorted out by physical examination. And that saves a patient being x-rayed and have that ionizing radiation and so forth. But of course, I mean, sometimes that is important. So there have been factors that have been associated with the increased risk and progression of osteoarthritis, including, of course, as you get older, and I mentioned female to male ratio. If you're heavier set or obese, then this can, of course, increase stress on the joints. If you've had injuries, for example, this can be problematic, especially meniscal tears and so forth. Occupational factors, like, if you're in a setting where you're constantly doing knee bending. As a chiropractor, we tend to get issues in our fingers. Massage therapists tend to get issues, in their joints as well, especially in the wrist and the fingers as well. And if you have any mechanical issues like excessive varus or valgus alignment issues at the knee as well. What's really interesting is that risk for osteoarthritis in the knee is not increased with recreational physical activity. So go out there and be active. It's just, people actually think that they shouldn't be doing things, or they blame their activities. And in fact, that may not be the case. In fact, it's usually not the case unless you've had an injury or what have you. So as we know, symptoms usually begin gradually. And men in their 40s or older, and women in and around the perimenopausal age or a little bit older as well. Pain's often dull, usually kind of feels around the whole knee, although it may be a little bit more localized, especially on the inside of the knee. It tends to start to increase as you use that knee joint more. You rest it and it feels a little bit better. And then, of course, as the osteoarthritis advances over time, then you may actually start having some throbbing pain or pain itself at rest, even at night, just driving, that kind of thing, and it can even interfere with one's sleep. One of the hallmarks is stiffness, especially first thing in the morning, or if you've been inactive for a while and then go to get up, you'll kind of like feel your knee is stiff, and that's sometimes called joint gelling, like jelly, because it kind of stiffens or tightens up. Now, if you look at an X-ray of the knee, this is at the top is your femur, at the bottom is your tibia. And now, if you look at the number A, it's a nice, normal, healthy joint. You see the nice spaces where the meniscus is and the alignment. Then on the right, you can see there's arthritis. Now, if you look, there's narrowing of the joint line, of the joint cavity. There's sclerosing, which is increased bone activity. There is an osteophyte there. Whoops. So these are the things that one's looking for when you're reading the x-rays. Now, bear in mind that you can have up to 40% degradation and wear and tear of your joint and not show up on an x-ray yet. So you can be well on your way to arthritis, and the doctor says, oh, no, looks good to me, you're fine. And in fact, you're not fine. Well, because you have pain there and such, and it could be the early signs of arthritis. So what I would say to everyone is start being proactive as you get into your 40s and beyond, because really, I mean, your whole life, but especially in your 40s and beyond, because that's when these things slowly start to creep up. Now, osteoarthritis in the knee is graded, and it really depends on the amount of tissue damage around the alignment and so forth. You can see it's graded from 0 up to 4, where 4 is basically bone on bone, where the hyaline cartilage in the meniscus is completely worn, and it's very painful and sore to weight bear, to walk, that kind of thing. We treat a lot of these patients in the clinic. Typically, they're going to be looking at a joint replacement, but we have found that laser therapy is really beneficial in reducing their signs and symptoms, even to the point where they've been able to, delay getting surgery. And you might say, well, why would you want to delay it? Well, replacements only last so long. And so, depending on your age, you may need two. So you're better off maybe just getting one, because who wants to undergo two major surgeries, that kind of thing, right? So treatment for osteoarthritis in recent years has seen a shift from, basically here's a pill, swallow it. Well, you know what? What's interesting is that that's still prevalent. I mean, you look at all the ads on TV or internet or whatever. It's all about, oh, take a leave, and you won't have pain for 24 whole hours. But they kind of forget to mention about the hepatotoxicity of these drugs, and how long term it can cause serious problems, worse than in fact your arthritis. So the shifting is understood that pharmacological therapy may be necessary at certain times, but is limited benefit, especially for slowing the progression down. And in fact, non-pharmacological approaches are more likely to relieve symptoms, in fact, even delay or slow down the functional decline. But this is a lots of different therapies, not just laser therapy. So really, the treatment of osteoarthritis of the knee is multimodal, not just one specific entity. So you need to be educated about everything from strength training and injury prevention and coping skills and being proactive. There's lots of things that one should be aware of when you're dealing with arthritis of the knee. And exercise is one of the key components of dealing with osteoarthritis of the knee. So it's contrary to sort of concerns that exercise is going to cause risk. There was a really good systemic review of studies that showed low impact exercise in older adults with knee pain, or OA, showed no increase in pain, and in fact, no progression of the disease with respect to imaging. So it doesn't actually make the condition worse. It can be very helpful. The goal of exercise is obviously everything from improving aerobic fitness to improving range of motion, strength, and as you get even older, reducing the risk of falls, which is really problematic. So there's many studies that have shown the benefit of things like treadmill and community-based walking and strengthening, neuromuscular exercises. If you're interested in that, just in general, if you're interested in exercises and things that you can do, go to gladcanada.ca. And this is a really great program for arthritis, for exercises. They do some online stuff. Highly recommend it. So if you have a chance, you can go there, and they talk about these specific neuromuscular exercises, along with things like aquatic exercises, balance exercises, mind-body exercises. They all have a role to play. Now, these neuromuscular exercises, they focus on reducing the weakness and improving your sensory motor control. So think of it like, going up and down stairs, off curbs, walking on uneven territory, that kind of thing, where you want the knee to be strong and be able to sense, where you are in time and space. And those kinds of exercises are really important. Aquatic exercises are great as well, but of course, obviously not nearly as accessible as these neuromuscular exercises. And balance exercises are also very beneficial. And they help functional instability, and again, for reducing the risk of falling. There was one specific randomized single-blinded control. I know it's only single-blinded, but they compared Tai Chi with physical therapy, and they found that Tai Chi, in fact, had similar improvements as seen with physio or physical therapy, according to validated osteoarthritis index at 12 weeks. So just those kinds of exercises are really, really important. So in general, exercise therapy ideally is initiated and personalized. So maybe work with a physical therapist or chiropractor, massage therapist, and anyone that deals with rehab. And this will be tailored to your needs specifically. And again, remember, this is a multimodal therapy, so there's lots of things that you can do to be helped. In general, they say 1 hour per week of moderate to vigorous activity was associated with a greater likelihood of remaining free of disability than activity lasting less than 1 hour per week. So that's kind of the golden bar right there. And people with osteoarthritis of the knee, if they were overweight, then, or if you are overweight, and I'm talking just, 5, 10, 15 pounds, everyone thinks, oh, wow, no, I'm talking about really overweight, then yeah, you definitely need to lose some weight along with that, because that will reduce the mechanical stress. There's lots of other treatments out there. I mentioned earlier about arthroscopic surgery. Specifically, they did something called partial meniscectomies, and they actually found that unless the person had knee locking, they weren't necessarily very helpful. So nowadays, we don't, or surgeons shouldn't be recommending that unless there's a real need for it. The other thing is that acetaminophen, which is commonly used for arthritis, remember that long-term use of it can have hepatotoxic effects on the liver. So just be really careful with that as well too. People oftentimes ask about glucosamine and chondroitin sulfate. There's not a lot of great evidence for it. If you want to give it a try, I think that's good. Some people do find benefit, but you need to try it for at least a couple of months before you say yay or nay to that. Something like PRP or platelet-rich plasma, there has been really good research ongoing with that. And that, if you have the cash for that, can be a very effective tool as well in conjunction with other things. So there's been some good research on that as well. One thing I do mention that's pretty cheap and effective is turmeric or curcumin. You can get this as a supplement. Of course, as a spice, we all know about it. But there's been some really good research to show that compared to the placebo, it actually has significant effect similar to a non-steroidal anti-inflammatory, but it's easy on the gut and it's natural. So I personally take this, and I stopped taking it for a while. I forgot to order it from Amazon or whatever. And wouldn't you know it, like I started to get some issues in my fingers, and I had never had that before. I swear that's why it creeped up. So yeah, I mean, I personally use it, and I think it is something that is very cheap, and certainly give it a try at least 2 months, maybe 3 months before you say yes or no to it. So why would you be using photobiomodulation or these personal therapy light systems? Well, first of all, we know that from research, it's going to reduce inflammation, reduce swelling. It causes the release of anti-inflammatory chemicals, so it reduces pain. It can actually work on cartilage and help cartilage regenerate and repair. Of course, it's not going to regrow it like you're a newborn, but it can help with that. It can help with muscle repair as well, and collagen production. So it has lots of different mechanisms that can help with all the different ways that arthritis affects the knee joint. When we use BioFlex laser therapy, we target all the way around the joint. It's not uncommon if you go for some laser therapy at clinics that don't use BioFlex, they'll use a specific laser probe or a small device, and they'll hold it on a spot for a few seconds or what time frame, move it around a little bit, and it usually lasts maybe 4 or 5 minutes, 6, 7, 8 minutes, and that's about it. While I'm not saying that's not going to be effective, what I am saying is that what you're not going to be doing is effectively treating synovial membrane, muscle tissue, and lots of the other structures that are really critical when you're treating osteoarthritis of the knee joint. You want to treat all the way around the joint and for a significant period of time, because that's what's going to stimulate the anti-inflammatory effect, the immunomodulation effect, and of course the repair effect. When you're treating the knee, it's important to have the knee in a certain position, especially when you're treating the joint line. Many of you may or may not be aware of this. It's called the open packed position. And that just really just means the position of the joint that is the most sort of loose, you might say. Whereas if you extend your knee, so if you straighten your knee completely out, it locks into position, and the joint itself is locked. So if you apply light therapy with an extended knee around the joint line, you're not going to get very much light into the joint. In fact, very little. So it's best to have it in an open pack position, which is about 25 degrees of flexion. One of the things I recommend is you can be sitting on the sofa or whatever and just prop up some pillows underneath your knee to position it so that it's slightly flexed like that to open up the knee joint. So when you open up the knee joint, this is kind of where you might see the joint line. And it's important to know where that joint line is. So you'll feel a ridge of bone. That's the tibia condyle. And then just above that, and literally like a few millimeters above that, is your femoral condyles. So if you palpate just away from your kneecap along that joint line, this is the medial, very inside portion of your knee joint. This is the most common area for arthritic knee pain and symptoms. So you want to place the array so it's right in the middle of that joint line. Remember, the knee's in about 25 degrees flexion, so that the middle of the light pad is in the middle of the joint line. And the equipment comes with straps that you can strap it into position, or you can hold it, but it might be a little bit easier just to strap it nice and firmly, not too firm to cut off circulation, but you want to have nice, good, firm contact. So that would be the first position I would treat, is on the medial or inside portion of the knee. The second position is on the outside of the knee. You can see this yellow dot, that's the head of the fibula. So you can sort of palpate or feel that bump of the fibula. And then if you just go above that, and again, you'll feel the tibial plateau, the bony ridge, and just above that is a femoral condyle, the lateral one, and the joint line, the lateral joint line. Now, the lateral joint isn't nearly as affected usually as the medial one, although that I have seen sometimes it quite problematic, but you still want to treat it because you want to treat the entire joint. So similarly, you're going to place the array over the lateral aspect of the knee joint, so the middle of it again is directly over the knee lateral knee joint line. So that's now two positions. The third position I always recommend is in the back of the knee. Sometimes that's referred to as a popliteal fossa. And this is really important because it helps control edema. Now, I will say this, is that you don't have to have the knee in the semi-flexed or the open pack position. You can have it extended because the goal here is not to get not to get light in the sides of the knee and into the joint cavity. It's to get it in the back of the knee where there's lots of blood, lots of circulation. And so this light will really promote anti-inflammatory effects in and around the knee joint. If you have Baker's cyst, which is not uncommon for arthritis of the knee, it's also an effective treatment for that as well, of course, depending on the severity and chronicity of the Baker's cyst. Now, a common location of arthritis is under the kneecap, and that's sometimes referred to as chondromalacia patella or patella chondromalacia. If you have this condition, and you know you have this one, if you get some grinding, you'll feel some grinding on your kneecap, you have some achiness under your kneecap, maybe some puffiness. There's a little test for it. You can kind of push down on the kneecap and it hurts. Don't try that one at home, folks. But so it's usually an indication, but it can only be diagnosed really with either specific imaging, like MRI, that kind of thing, or orthoscopic imaging, but it's really common. So if you do have this problem, then I would suggest doing a fourth placement over the kneecap. So align the pad, strap it into position, and place it so that the middle of the light pad is directly over the kneecap, so the margins all the way around the kneecap are being treated as well. So you could be doing up to 4 placements. So yeah, this is going to take a while to treat. So I'm going to suggest that you watch your favorite Netflix show or read or do something proactive while you're getting treated as well. Let's go on to the treatment stages. There are 4 of them, and these represent increasing dosaging and or frequency, which is a pulsing of light. So typically these 4 stages are what's going to control, what you will use to control your treatment over a period of time. Stage 1 being the lowest, and of course stage 4 being the highest stimulatory stage. So we always do recommend to start at level 1. Don't be a cowboy and start at level 4 because the whole point to these protocols designed decades in our clinic from Dr. Khan is that they're meant as a starting point, and level 1 is a really good starting point. And give yourself some time, maybe a couple weeks, maybe 3-4 weeks before you go, I don't feel much change, or maybe you felt change and then it's kind of leveled off. Then you would go to the next stage. I would really prefer that you don't go from level 1 or stage 1 to stage 2 too quickly, because your body does need time. When you're treating a progressive disorder like arthritis, it's been growing for decades, right? So if you actually expect monumental changes in a short time frame, then you've come to the wrong place. That's not how it works. And nothing's going to work like that other than taking a really strong medication. Of course, that's just blocking pain and not doing anything for the condition. So be patient, is the name of the game. So if you feel your symptoms are improving, then continue with that particular stage. Now, if you feel your symptoms are not improving, then make sure you're dealing with what you think you're dealing with, right? So first of all, I always recommend that you see a healthcare professional to get a proper diagnosis, because what you may think was arthritis may be something else. So make sure you get a good diagnosis. As I mentioned earlier, don't advance the stages too quickly. And obviously avoid aggravating your symptoms. Sometimes what happens is you might feel better and then you just go, oh, okay. And then you start doing stuff and then like too much or what have you. And then next thing you know, it's like, oh, I'm hurting again. You need to be aware and be realistic as to what you can or can't do, especially during treatment, because you're trying to get yourself better and give it some time. So if you do find that you've just plateaued or things aren't going great, take some time off, maybe 2 weeks, 3 weeks or so, and then reinitiate laser therapy. That oftentimes seems to do the trick. Sometimes the body accommodates. And so when you give it some time and then reinitiate treatment, that may also be very helpful. As far as how to approach treatment, if your knee is quite painful, so you might see it's an acute flare-up of arthritis, it can be red, or there's swelling or heat, that kind of thing, then I'm going to suggest you treat on consecutive days, 3, 4, 5, 6, 7 days in a row, try and get it calmed down, then start to treat every other day. If it's chronic, so like some achiness and that kind of issue, then you don't necessarily have to go gung-ho and treat on consecutive days, although you can still do that. But you're still probably good to start off just treating every other day, 2-3 times a week, 4 times a week, until you get under control. In general, once you feel you're about 50% improved or thereabouts, you can start going down to about twice a week. And then once you're getting up there, 80% plus improvement, maybe down to once a week. And at that point, I would say a maintenance and probably once a week or a few times a month would be what I'd recommend. But everyone's different. Sometimes maybe once a month, but you will kind of know your own body, so you can address that appropriately. By the way, I'm nearing the end of my time, so if you have any questions, you can just type those in. So really, the big picture here is to treat the entire circumference of the knee joint. Don't take short steps. And remember, treat around the patella or the kneecap as well. Don't forget to treat in the open pack position. That's really important. Look at these other types of things, from exercise therapy and turmeric and what have you, some other therapies. It's a multimodal approach. One thing is not going to be a panacea, but you need to be progressive and you need to take things into your own hand and try different things and see what works, what doesn't work. Okay, so thanks very much. That was a really fast half an hour. We do have some upcoming certification trainings. If you haven't been certified, please join us on Friday, September 17th or October, November. All these dates are on our website, so you can go there and register. I do have a advanced training for cervical spine conditions with keynote speaker Dr. Ben Ewan out of Halifax, and Slava Kim, our clinical director, along with Nathan Chung in our clinic, and myself. That's coming up on Saturday, September the 18th for 4 hours. If you have a chance We have an ongoing early bird special. So if you want to register, I'd suggest you do that. And we have one on aging and cosmetic conditions as well into December.